My dear students, welcome to this one-shot surgery revision session for upcoming January FMGE examination. January 12th is the most important day, yes or no? So I hope you're all preparing well and revising all the subjects repeatedly. So today in this session we'll quickly revise all the surgery topics including previously asked questions as quickly as possible, including all the important high yielding topics along with the PYQs. Okay, please be with me. This is going to be a interactive session, so I'll be asking many questions in between, so please be prepared to answer them, and if you have any doubts anytime, please feel free to post it in the chat section in the YouTube live, so we'll get them answered there itself. Okay, so coming to the most important topics list, the beginning, from the general surgery, I would recommend trauma as the most important high yielding topic. I'm very sure 4 to 5 questions going to come from this topic alone for you, in the, mostly from the case scenarios, okay, or also some investigation of choice or any other questions. We'll discuss them, but this is going to be a major chunk of questions from trauma, so please revise well. Secondly, from burns, one question will be there for sure. Breast, you know, this is a very important topic for any entrance exam point of view. Breast malignancy staging, okay, which we should know. Thyroid malignancies also, there are 4 types of malignancies, so any one question from them is confirmed. And hernia is also a very important topic for all of us as UGs, so one question can be asked from hernia. Even last year also there was one question. From vascular surgery, from any Burger's disease, varicose veins, DVT, aneurysms, there could be one question. Coming to systemic surgery, from esophagus, mainly there are 2 topics, you know, that is achillescardia and GERD, which is examiner's favorite. So we can expect one question from them or its related complications. And from intestine, there could be a question. Appendix is always a favorite question of all the examiners. We should be well prepared for that. And last year there was a question on fistula also. So fistula and hemorrhoids also important. In the stomach cardiac stomach and peptic ulcer disease are important. And yet another important subject for us is urology. From urology we can expect many questions, especially the appearance of urinary stones, BPH and its management, and there could be some image related questions, phimosis, posterior urethral valve, hypospadias, priapism, penile cancers, testicular torsion, and there was last year question on undescended testes. We will discuss all these and including some other important topics which could be a potential question this time. So hope you are all ready for the discussion. Any more clarification required at this juncture? Please post them in the waiting chat section. Okay. So first let's discuss about trauma. Trauma, what's very important is triage. In trauma, as you know, I'm not going to the details of everything, and detailed discussion is not possible, but what is very important in the entire topic, we will just discuss them. Okay. So in trauma, what is important is the triage, the tags, you know, the red tag, yellow tag, green and black tag, which one is for which one you should know. And then you please don't forget, because all the questions will be based on this one protocol, that is ABCD, ATLS protocol. In the primary survey we follow ABCDE. So most of the questions will be based on this basic understanding. When patient came with this case scenario will be there, and they will ask you what is your preference of management. So always in this steps only. First is airway along with restriction of cervical movements. Remember this. Okay, only protection of cervical movements in the A. B for breathing, which we include identifying any problem with the ventilation and oxygenation and correcting it then and there itself. Okay, airway, find out the problem and correct it. Next, breathing, find any problem, correct it. Then go to the C, only then. Even though there is what the most common question they ask you to confuse is There will be torrential bleeding happening from the open fracture of femur, and patient is having unconscious and lying down with the GCs of 8 and all. So what you will do immediately? It's not the bleeding control. First is always airway. First, because airway is immediately life threatening. Okay, within seconds patient may lose his life. But bleeding will take time. Okay, there is 4 to 5 liters of blood. For it to get exsanguinated, it takes time. So, but airway can be blocked in within seconds, and that can lead to, it can be life threatening. So airway is always a priority, and then always fixation of the cervical movements, then breathing, then only whatever the bleeding is there, then the disability and exposure, in this order. Okay, in some of the books it's given CABCD and all. That's as per the NICE guidelines which given in Bailey, but we don't follow that. In our India we follow ATLS guidelines. Okay, so in that ATLS guidelines says it is ABCDE. Please stick on to that. Okay, hope it's clear. Okay, these are the immediately life-threatening conditions we all should be aware of. Any airway obstructions, tracheobronchial injuries, and tension pneumothorax. There will be, I can bet on that, there will be definite question on tension pneumothorax this time. Okay, now in the form of image, X-ray, or what you immediately do for tension pneumothorax, like needle thoracostomy that has to be done. That one question will be there for sure. Open pneumothorax is also life-threatening. Massive pneumothorax, cardiac tamponade, Beck's triad and all, and traumatic circulatory arrest. These are all the immediately life-threatening conditions. Okay. This is what you do in the ATLS protocol: scene safety, check the response, call for help. All these things you know very well. First thing is always check for the airway. In the airway, then immediately check for the airway. If no problem, then cervical collar you put to secure the to limit the movement of the cervical spine. Only then, how do you? This can be asked as a question. How do you maintain the airway? Maintain the airway. If the airway is compromised, you can initially make it clear by using chin lift method and jaw thrust maneuvers. These are the two common maneuvers used to clear the airway. Then you put Philadelphia collar to restrict the cervical movements, and then you see first airway checking, then in this order only, checking the airway, then next immediate thing is the cervical collar protection. Third thing is management of airway. This is very, very important understanding, because to manage the airway you need to do sometimes intubation and all. While doing intubation, your cervical spine may move and cause more damage. So first secure it, basic understanding. Okay, so you secure the spine and then only do whatever the airway management, like intubation or whatever. Okay, so if you ask me the sequence, it should first airway checking, then cervical spine protection, then maintenance of airway. This should be clear in your mind. Okay, this is very, very clear. Okay. Then this one chart will make your life easy in any exams. Okay, very important, how to differentiate clinically between simple pneumothorax and tension pneumothorax, massive pneumothorax and simple pneumothorax. What happens to the respiratory rate in each of the condition, what happens to the blood pressure, what happens to JVP, how can you, many a times it question asked, how do you distinguish between pneumothorax and the tension pneumothorax, mainly by your percussion and auscultation, right? Percussion in the tension pneumothorax it will be hyper resonant, whereas in the massive pneumothorax it will be dull. Okay, and this one chart is very, very important. Okay, types of pneumothorax, this one image is very much important for you, how to identify pneumothorax and what is tension pneumothorax. See, the entire mediastinum is shifted to the opposite side. There is a tension pneumothorax here leading to mediastinal shift. Okay, this is simple pneumothorax. This is a simple pneumothorax. We can see the right lung which is compressed here. Okay. So this image is a very high yielding. Okay, this is a hemothorax. Massive hemothorax is here. Massive hemothorax. This is simple pneumothorax. Simple pneumothorax here. Okay. Or this again pneumothorax is there. See? Pneumothorax. There is no mediastinal shift. So it's simple pneumothorax. Again here also there is a pneumothorax. Okay. So triangle of safety, what do you do in pneumothorax? How do you manage pneumothorax or hemothorax? By inserting a intercostal drain. Correct? Intercostal drain. So where do you insert this? Triangle of safety. What are the borders? You know. So this is what triangle of safety, and how do you insert the ICD and how do you place it and all, we should know. And next comes the flail chest. Yes, very important, and at another yielding topic is flail chest. You please make the clear about the definition. It is 2 or more consecutive ribs at more than one point in a line. Okay. So mainly it leads to what's called paradoxical respiration. The entire rib cage moves out with inspiration and moves out with expiration, whereas the flail segment, whatever is there, that moves in a reverse direction with the entire rib cage. That's called paradoxical respiration. Management, initial management is oxygen supplements, because some part of the lung is not moving because of pain. So the saturation may be low, so you maintain with oxygen and mainly pain control. Rib fracture is there, so it will be very painful. So control the pain and auto inhalation. So that will take care in most of the cases. But there is a features of any respiratory failure, like saturation drops below 85% or partial pressure of oxygen is less than 60 mm of mercury, then you have to go, what is the treatment of choice? If they ask, it is IPPV for flail chest, intermittent positive pressure ventilation, IPPV. Okay. And most common cause of death they have asked multiple times in case of flail chest is pulmonary contusions. They bleed and then they can lead to atelectasis and patient may die. Investigation of choice is chest X-ray, whereas gold standard, any rib fractures can be well made out with X-ray itself. But to know the underlying any damage to the parenchyma or any other associated injuries are there, to check for that we need CT thorax, but we don't commonly employ that. So investigation of choice is chest X-ray, with which we can start the management, but gold standard investigation for flail chest, if they ask, it is CT thorax. Okay. So flail chest is important. Yes. Coming to the most important aspect of trauma is circulation. Okay, although airway and breathing is the priority, but most of the time questions and the scenario is based on the circulation. Okay, so hemorrhagic shock, you all know there are 4 classes: class 1, class 2, class 3, class 4. All the features we should know. What happens in class 1 to the heart rate, blood pressure, pulse pressure, respiratory rate, urine output, GCS, waste deficit and need for the blood, whether it is there or not. These things, the questions will be based on these parameters only. Okay, there is a blood loss of 1.5 to 2 liters with the heart rate of around 120 to 140, and there is a urine output is decreased. They ask you, then what is which class of hemorrhagic shock is this? They can ask you, or whether there is a need of blood is there or not. They can ask you like this. So just note here in the entire chart, most of the things gets changed in the class 3. Okay, class 1 is compensated, everything will look normal. Okay, except for the base deficit, which is not clinically manifested. So in class 2, some changes like tachycardia sets in. Okay, but BP and all maintained in that, and base deficit is still there. But in class 3, what we can know, there is a typical tachycardia and BP starts lowering in this stage, and pulse pressure also, and urine output is decreasing. GCS is, patient is becoming semi-conscious in this stage. So most of the changes happen in class 3. So class 3 is most commonly asked question for you all. Okay. Okay. Then how do you manage circulation? See, the question is, what they ask is which cannula they use for circulation management. Commonly asked question. It should be always to widest bore cannula, not just wide bore, widest which is available. Okay, there is no blue cannula, green cannula, no, that's not the answer. Whichever is the widest among all available. Okay, so that should be the answer. If not available, or if not cannot be cannula could not be put, then we go for intraosseous cannula, the tibia, or if that's not possible, then we go for venous cut down in the great saphenous vein or in the brachial vein. And fluid of choice is always crystalloids, And the best fluid, if they ask, hemorrhage is, there is a loss of blood, so best replacement would be blood itself, but it's not immediately available, right? It requires time to arrange the cross match blood and all. So immediate fluid of choice or fluid of choice in general is crystalloids, whereas best fluid, if they ask, blood. In that also, which is the preferred blood, is cross match blood. Okay, cross match blood, but to get a cross match blood, it 45 minutes to 1 hour it's required. So most commonly used blood is O negative. See, each word will make your answer different. Which is the fluid of choice is crystalloid. Which is the best fluid is the blood. Which is the most preferred fluid is cross match blood. Which is the most commonly used blood product is O negative, PRBC, like that. Okay. And during resuscitation, what's the best guide for the fluid infusion? If they ask you, it is urine output is the guide. What is the minimum urine output required in the normal person is more than 1 ml per kg per hour for kids, more than 0.5 ml per kg per hour for adults. This has to be maintained. That is the goal of fluid resuscitation. And the requirement of fluid, whether the fluid is required or not for that particular patient, is assessed by pulmonary capillary bed pressure or central venous pressure. PCWP is better, but it's very invasive and very difficult to measure. So CVP is a commonly employed one, but the best one is PCWP. Okay. So nowadays we have come up with they have come up with a new concept called permissive hypotensive resuscitation. Means we know the normal blood pressure is 120/80, we say, but in case of hemorrhage, we don't expect to normal blood pressure. We don't want to bring the patient to a normal blood pressure while resuscitating. We just want a pressure to maintain the blood flow to the vital organs. Okay, that is around 90 systolic is enough to maintain blood pressure to the vital organs like brain, kidney, liver and all. So we maintain at that range only. So because you understand the pressure is higher, bleeding also more. Correct? So now this is called balanced or controlled or permissive hypotensive resuscitation. There is a hypotension, but that's okay because the perfusion is maintained. We need not have to have a perfect BP, but near normal BP is expected in that case. Okay, and this is another question. Nowadays we don't give any one particular type of fluid. Instead we prefer in any blood we give in this ratio. PRBC is to FFP is to platelets 1:1:1. Okay, and nowadays in the recent protocol they have come up with the role of injection tranexamic acid also in case of bleeding. So that can be asked as a question. Yes, this one chart, please know this. Many questions, many image based questions are question asked. Which color codings for IV cannulas, and you should also know what is the gauge and what is the flow rate, you should know, and in which condition it's used. See, in trauma what we use is the widest bore, that is of orange. If the orange is there in your option, that should be the answer. If orange is not there, gray is there, then that is the answer. Oh, like that, whichever is widest bore available in your options, that should be correct in your for the trauma question. Okay, hope it's clear. This one chart, please know this in detail. Okay, then coming to hemorrhagic shock, very important. Hypovolemic or hemorrhagic shock is very important. Signs we should know. What is when we say patient stable, unstable, we should know, and what are the common sources of bleeding, we should know. And yeah, there are some non-hemorrhagic shocks also. Mostly you learn in medicine, like neurogenic shock and cardiac tamponade can happen, and tension pneumothorax also can cause shock. Only thing one typically asks the question is patients having hypotension and there is a bradycardia. Once the bradycardia comes, it's neurogenic shock. Rest all the shocks they will have tachycardia. Please note, in neurogenic shock there will be bradycardia. Okay, and there will be, of course, it's a warm shock. Warm extremities will be there. What is the treatment for each? Please know. Disability. In disability, what we should know is the GCS. GCS scale, many a times asked question repeatedly, and nowadays what we have is GCSP. Not just GCS. In GCS there are some drawbacks are there. Just what we learned in our UG days. So nowadays we use GCSP, including the pupillary reaction. Okay. This question was asked recently in exam. What are the agents or the tools used in primary survey? Pulse oximetry we use for saturation. For ABG we use whether there is to know whether there is a respiratory failure or an acidosis is there. ECG commonly employed. X-ray. E-fast, we know what is E-fast in abdominal trauma. We'll discuss that. Foley's catheter we put to check for the urine output, and Ryle's tube we put inside to do any aspiration or irrigation. So these are the primary adjuncts. Nothing other than this. If anything other than this is given, it's not used. Okay. So you know damage control surgery. There is something called damage, means do the needful, do the minimum to save the life. They are not doing the definitive thing here. Do the minimum thing to immediately save the life. So that's called damage control surgery. And triad of death, you know, that is acidosis, hypothermia and coagulopathy. To prevent this happening, you do damage control surgery. That is mainly physiological correction is more important than anatomical. Okay, that's the basic objective of damage control surgery. And these are the phases of DCS. Multiple time asked question. Okay, phase of DCS 0, 1, 2, 3, 4. In stage 0, you have phase 0, you do patient selection. Patient with acidosis like less than pH, less than 7.2, PTA, PTT deranged more than 50%, hypothermic patient less than 35 degree Celsius, or serum lactate is already more than 5. Okay. In the phase 1, you do control of bleeding or infection in minimal possible time. Stage 2 is ICU resuscitation. Phase 3 is definitive treatment. Once the patient is all resuscitated in the ICU, when the patient is stable, then you can do the definitive treatment. And the stage 4 is for incisional hernia repair. Of course, when you do something surgery in an emergency, it will lead to incisional hernia. That you do in stage 4. Head injury is the very, very important topic. Head injury, what is the problem with this is, it usually increases the intracranial pressure, which is vital for the brain perfusion. So, if it increases, what are the symptoms? There will be altered sensorium or loss of consciousness, or repeated projectile vomiting could be there. A patient can throw seizures. There will be very severe headache, and there are some signs associated. This will be image-based question for usually in FMG exams. Typically in anterior cranial fossa fracture, there will be what is called a raccoon's eye sign or panda sign will be there. Raccoon's eye sign or panda sign. And then there could be, if the cribriform plate is injured, then there could be CSF rhinorrhea also. In case of middle cranial fossa fracture, there could be behind the mastoid here, over the mastoid process behind the ear, there could be ecchymosis. That's called battle sign. Battle sign. This is raccoon's eye sign or panda sign, and whereas the over the mastoid process, it's called battle sign. Or there could be a hemotympanum also, CSF otorrhea or CSF rhinorrhea could be there associated. Okay, this is all seen in mid cranial fossa fractures. In any case of head injury, the first thing is assess the GCS. Okay, as per the GCS score, we categorize the patient into mild head injury, moderate and severe head injury. Okay, in case of mild, we can just observe, whereas in the moderate or severe, immediately get a NCCT brain, and depending on the what's there in the NCCT brain, we further manage. Okay, and see this is the GCSP score, what I was telling. Okay, this is the most important prognostic score in any head injury patient. Eye opening, we know, verbal EVM 4, 5, 6, you remember that way. Eye opening, verbal response, motor response, among which motor response is the most important prognostic criteria. Whereas scoring 4, 5, 6 maximum. And nowadays we have a new thing in the modified GCS, that is, there is something called non-testable. See, for example, if the patient is having a severe edema in the eye, how can you check for the eye opening? If even the patient is want to open or willing to, able to open, is unable to because of the swelling. Correct? There is no other problem. So this is categorized under non-testable or NTU. Put it as E, you write as NT, means non-testable. Similarly, verbal response also, that also there is a non-testable. If the patient is earlier we used to write VT, right? Patient is tracheostomized. Nowadays it is written as NT, non-testable. In the motor response also you can write non-testable. One more thing, what newly added is GCSP score is there is pupillary reaction. If both the pupils are non-reactive, you give a score of 2. If the one pupil is non-reactive, score of 1, and both the pupils are reactive, then give a score of 0. Okay, you have to deduct this from the whatever the GCS score you get and write the final score. So this is GCSP score, the new modified one. Please know about this. Then there are so many other types of head injuries like EDH, which is the vessel injured. You should know in each case. Here the anterior branch of middle meningeal artery is injured. Most common site is temporoparietal region, just above the T-rheum. Okay, and what is the classical feature of EDH is lucid interval, alternate consciousness and unconsciousness. Okay, and what is the typical NCCT feature in case of EDH? Can anybody say what is the most common feature in NCCT brain in case of EDH? How it looks like EDH? Please answer in the chats. Very good. Correct. Shahnawaz Khan is very good. MMA. Which is what is the typical appearance you get? It's not idli shape. Yes, biconvex shape, not biconcave. It should be biconvex shape. Okay. Yes, very good. Correct. 1 second. Give me 1 second time. Okay. Same. Adapt ಇದೆ C2 ಅಡಾಪ್ಟ್ ಇದೆ ಬಟ್ C2 ಇದು ನಮ್ಮ ಯೂಸ್ ಬಿಟ್ ಆಗಿದೆ ಕೂತಿದೆಯಾ ಅಡಾಪ್ಟ್ ಚಾರ್ಜ್ ಬೇಕು sorry, the MacBook charge is getting over. I don't know, it was fully charged. I don't know what happened. I'm really sorry about that. It may just ask for my charger. 1 second. Okay, fine. So let's continue. Yeah, so in EDH what you get is typical, what you told is right. You get biconvex or lenticular shape, like this lenticular shape or biconvex shaped density in NCCT. And another thing what we note in EDH is there is something called lateralizing sign. What is that? We'll see. That is there will be ipsilateral, whichever side is there is EDH, the pupillary dilatation will be there, and on the opposite side there will be hemiparesis. Okay, that's called lateralizing sign. One of the lateralizing signs we get in EDH. Okay, and for the treatment of EDH is burr hole or craniotomy. Next there is a SGH and SH is also there. See, these are the typical appearances what we get. SGH is concave or convex type, whereas EDH is biconvex type, correct? And SH will be irregular shape in the subarachnoid space, like this SH, okay. So which are the vessels? SH is Berry's, usually the Berry's the ligament, Berry's aneurysm rupture can lead to circle of Willis can have Berry's aneurysm. If its rupture can lead to SAH most commonly, thunderclap, headache, all those things are features. And SGH you know, okay. And then there is something called diffuse axonal injury also. Management of head injury is aims at mainly decreasing the ICP, decreasing the ICP, and we can try by medical management, like giving the 100% oxygen, or with the initial hyperventilation or elevation of the head end of the bed, maintenance of normovolemia, hypotonic saline, etc. But in some times, in some conditions, even with this medical management, it's not improving, or if the NCCT shows more than 30 ml of blood, or if the ICP is very high, like more than 20 mm of mercury, or patient is deteriorating in GCS, if there is any lateralizing signs, then we have to go for directly for surgical management, okay. Remember this one point, multiple times asked question, anytime the GCS is less than or equal to 8, endotracheal intubation is should be done, it's required, okay. GCS 8 or less than 8. Then coming to the neck injuries mainly cervical spine injury, correct? And in the neck there are only spine is there, then in the anteriorly there are so many soft tissues are there that can get injured, like the artery, vein, the nerves, trachea, esophagus, all these are soft tissues present that can get damaged. And for cervical spine injury, how do you know there is a cervical spine injury is there or not? How do you clinically assess? There is something called nexus criteria, okay. If any neurological deficits are there, patient is intoxicated with ethanol, any extreme distraction force was there applied on injury, unable to provide any history, or any spinal tenderness is there, then you assume to have cervical spine injury. Immediately protect the cervical spine with a Philadelphia collar, then get a CT spine, okay. Then if there is injury, treat it accordingly. In soft tissues of the neck can be categorized into 3 zones: zone 1, zone 2, zone 3, from below upwards, okay. So these zones you should know. Each zone, depending on the patient is stable or not, you get, if the patient is stable, you have all the time to get all the investigations done, where exactly is the injury, how exactly is the injury and all. But when the patient is not stable, you have to immediately explore the neck, okay. Thoracic injury, important. Most important thoracic injury is rib fracture, and rib fracture, main thing is pain management. I told you already, pain management. Best, they have asked you what is the best treatment for rib fracture, that is epidural analgesia. Coming to aortic injury, what is the typical feature you get in aortic injury in X-ray? On X-ray, what is the classical appearance in aortic injury? No answers? It is widened mediastinum. Mediastinum will look wider. See, here the mediastinum is widened. Okay, that's the classical feature. Then there will be obliteration of aortic knuckle. Aortic knuckle is usually like this. That will be obliterated. Okay, and left bronchus will be depressed, and there will be some underlying rib fractures will be there. Okay, and diaphragm injury is not very important, and abdominal trauma is very important. In that, what is more important is that E-fast. What is extended fast? Earlier we used to do just fast. Nowadays what we do is E-fast. Where are the sides of fast? We should know. That is, one is epigastrium, 2, 1, 3 right upper abdomen and left upper abdomen, 4 is suprapubic region. What is E or extended part is costo. We look at the costophrenic angles also to look for any pneumothorax or hemothorax present. Okay, for that we check for the costophrenic angles if there is any minimal correction is there. So there is a E, extended fast, we should know, and yeah, anywhere in any abdominal trauma, what's important for you is when the patient is stable, you get all the investigations like CT, USG, all those things done. When the patient is not stable, patient is unstable or having any features of peritonitis, immediately explore. You don't have time to see. Sorry. Really sorry. Okay, really sorry for that inconvenience. Okay, somehow suddenly my MacBook got drained and it was fully 100% charged. That's what happens just before the exams also. We'll be fully studied and fully prepared, but suddenly on the exam day we drain out. We get exhausted or become thought blocked or something. It was not getting on even for quite some time. And suddenly, somehow, okay. So let's continue with the discussion. I'm once again really sorry for that wasting your time. So the simple rule you keep in mind in case of any abdominal trauma, that is, if the patient is stable, you can have all the liberty to get all the investigations done in that patient. Okay, you can get ultrasound, CT scan, or whatever you want, CT angio. But if the patient is unstable, exploratory laparotomy. So there are two types of questions they ask. What is the most appropriate next step? If the word next is there, what is immediately to be done when the patient comes with the abdominal trauma? What is the immediate next investigation or next step? If they ask, that is always fast. Whereas, what is the most appropriate step? If they ask, then if the patient is stable, then you get a CT scan. If the patient is unstable, you get a exploratory laparotomy done. Okay, hope it's clear. Each word is very, very important, and you have to read between the words. Okay. Next step is different from the best step or the just what is the most appropriate step. Hope it's clear. Okay. So depending on the fast report, we further managed any liver injury, splenic injury, kidney injury, any vascular injury. Depending on that, we manage. Okay. So see, this is one example I'll give you. They ask you most appropriate step or the investigation of choice in case of blunt trauma abdomen in a stable patient, then it is CECT. Whereas if they just mention which is the next step or which is the first step in case of any abdominal injury, be it patient is stable or unstable, but the next step or the first step, if they ask, the answer is fast. It is the most sensitive investigation. Even the fast sometimes can miss some minimal bleeding or so. But the most sensitive investigation, if they ask, that is DPL, diagnostic peritoneal lavage. Minimum amount of fluid which visualized on fast is 100 ml. okay, not less than that. Okay, so that time DPL may be helpful. So these are the previously asked questions you have. So that was in blunt trauma abdomen. In case of penetrating trauma, again the criteria is the same, whether the patient is stable or unstable. If the patient is stable, you get all the CT scan, everything done. If the patient is unstable, immediately exploratory laparotomy. No need to wait for any type of investigation. Hope this dictum, it should be very clear in your mind before attempting any MCQs. Okay, so in case of, see again same, in case of any penetrating injury, stable patient, the investigation of choice is CT scan, whereas the best investigation is laparoscopy. You yourself go inside and visualize for yourself what is there, what injury is there. That is the best. Best is different from investigation of choice. Investigation of choice is the which one which we commonly involve or commonly do. That is investigation of choice. After which we can directly treat the patient. That is investigation of choice. Best is which we may not do every time, but which has got high sensitivity and specificity. That is best. And then the retroperitoneum is not very important for our level, and bladder injury is also not very important. Urethral injury, that straddle injury they ask you, it's the most common part of the urethra injured in any straddle injury. That is bulbar urethra, you should know. And other than that, blast injuries, there were so many questions in every paper on blast injury. There are 4 waves in any blast injuries. That is primary wave, secondary wave, primary injury, secondary injury, tertiary and quaternary injury. Okay, in case of blast waves. So primary is due to the blast waves and sound waves, whereas secondary injuries because of any penetrating injury, because of small blast fragments will come and penetrate the body. That's secondary injuries. Whereas tertiary injuries because of the blunt objects due to the blast wind itself. What are the propulsive blast wind is there, that will come and hit us, will go thrown away and will fall and get some blunt injuries. That is tertiary injury. But quaternary is this burns, blast flames will come and cause burns injury, right? These are the quaternary injuries. Most common organ injury, remember, multiple times repeated question, is tympanic membrane. This is the most common solid organ if they ask, that is lung. Which is the most severely injured? See, every word is different. Most common is tympanic membrane. Most common solid is lung. Most severely injured organ is lung again. Okay, so which is the least common affected is any other solid organs like liver, kidney, spleen, everything. Okay, so most common cause of death in case of even blast injuries also pulmonary condition, just like flail chest if you remember. Okay. Next, seat belt injury, some questions have been asked, which is the most commonly injured organ, that is mesentery. Okay. Then comes the proximal jejunum, then the terminal ileum, then the abdominal aorta. In this order only, the the frequency of seat belt injuries. Okay. Vascular injuries, in case of any severe injury is there, hard signs like significant hemorrhage with the patient having hypotension or pulsating hematoma is there, or signs of any distal ischemia, immediately explore. Whereas soft signs like there was history of hemorrhage, small hematoma present, and some neurological deficits are there, then you evaluate it further with CT angio, then you can proceed with the management, like you can do either primary repair of this thing, or you can do resection and anastomosis of that vessel. Okay. Crush injury, multiple time asked question because of its known complication of rhabdomyolysis. The muscles get lysed, resulting in release of myoglobin, which is a bigger molecule, can't be passed through in the glomerular filtration membranes, so can result in acute tubular necrosis, resulting in renal failure. Okay. Also can result in, because of the cell lysis, lot of potassium is released into the circulation, causing hyperkalemia. And also, if there is a crush injury within the compartment, it can increase the compartmental pressure, leading to compartment syndrome. All these are very deadly. That's why crush injury is very, very important to diagnose and to evaluate and do the needful immediately. Okay, so there are so many trauma. There are so many scoring systems are there. Scoring systems, it's like TRIS scoring is there, and what commonly asked question is this one. revised trauma score. What are the components? Because there are three. They'll ask four. They'll give four options and they'll ask you which of the following is not a part of RTS, that is revised trauma score. GCS, SBP, and respiratory rate. Okay, these are three components of revised trauma score. Next, burns. At another important question. One question definitely you can expect from this topic, burns. So the grades of burns, what is superficial, what is deep, what is primary, secondary burns, okay, you should know. What are the features of each thing, you should know, okay. And this will be another question, like how to calculate the percentage of body surface area. What we commonly use is rule of 9, right? It is commonly used, but which is the most accurate if they ask, that is Lund and Browder's chart. Lund and Browder's chart is the most accurate one, whereas the most commonly used one is rule of 9, Welles rule of 9. It's called Welles formula. Okay, so how do you save any? How do you manage any burns patient? Same ABC formula. Then the most important thing is fluid resuscitation. We use Parkland formula commonly employed. 4 into percentage of body surface area involved in burns into kg, and we calculate the total amount of fluid to be infused. Then half of the amount is infused in first 8 hours. Okay, we were discussing about the burns fluid management, Parkland formula, and again, there the fluid of choice is always crystalloids initially. Okay, initially RL or NS we give, and then after for 24 hours we may prefer to give colloids there. Okay, colloids like albumin, FFP can be given. Okay, and then the question can be based on the frostbite. What is frostbite? Is severe cold injury can result in frostbite. Again, electrical burns, one we should know, because there what happens is the electrical burn injury that interferes with the cardiac electrical activity result in arrhythmias. So that's the danger there. So ECG is the must there, ECG monitoring, and there is also high risk of rhabdomyolysis, which can again result in renal failure. So this is very dangerous, electrical burns. So that's about the burns. Then another topic which they commonly ask questions on is breast lump or any breast disease, like mainly malignancy. The most common malignancy worldwide is breast, and its most common symptom of any breast disease is breast pain or mastalgia, whereas most common symptom of CA breast is painless lump. That should be clear. Most common complaint of any breast disease is breast pain. The opposite of a CA breast is like painless lump. We know about triple assessment. Any patient comes with breast lump, we do clinical history and examination, then we do radiological examination, and then pathological examination. That's about triple assessment that we should know. But the most common questions they ask in this topic is about BI-RADS staging. You know this BI-RADS. Okay, the breast imaging reporting and data system. There will be question based on these. What is category 1, category 2, category 3, what is the recommended action, what is the likely chance of cancer. This one chart you should be thorough about. It's available in all your books, notes is everywhere. So please be thorough about this particular notes. And also this is another question, what are the features suggestive of malignancy in mammogram. Okay, that's yet another important question. And about see, questions will be like this. Typically these are the typical questions you get in exams, like a 45-year-old lady comes with a lump in the breast, mammography shows macrocalcification. Okay, what is the BI-RADS score, or what is the BI-RADS recommendation? Macrocalcification is benign feature. So it's BIRATS 1. Whereas 45-year-old female with hard lump breast, mammography shows BIRATS 2. Then what is the management, like that? So everything will be related to BIRATS and clinical examination. And in case of high risk patients, you can get MRI breast. So what are the roles of breast? Where is MRI of breast is done, you should know. And tissue sampling, there are two types. Either can be done through core needle or true cut biopsy, or nowadays what we use is vacuum assisted breast biopsy, also called mammotome. Why? You please tell me why core needle biopsy is advised or recommended than FNAC, normal FNAC we do for biopsy, right? Here we in breast we do core needle biopsy. Can anybody tell us why? Why we prefer true cut or core needle biopsy over FNAC? Here the advantage is, along with the cytological study, we can also do the invasiveness, whether it is going beyond the cells, we'll come to know. Also know about the receptor status. As we know in breast cancer, they're all hormone related, like estrogen receptor, progesterone receptor, HER2 receptors, all this can be involved. So this receptor status also can be well made out with core needle biopsy. Accordingly treatment varies, so this is preferred. Okay, so here also many questions can be, example can be like this. A 45-year-old female comes with hard lump in the breast. Okay, so that is suspicious, clinically you are suspicious of malignancy. What is the most appropriate next step? Okay, that is different from most appropriate step. Hope it's clear. Most appropriate next step is, after clinical examination, next is a radiological. In a 45-year-old, what you get? Mammography. If it's less than, younger lady less than 40, you get a ultrasound done, like that. Most appropriate step will be biopsy, like that. So CA breast, all the theoretical aspects you should know. It's a very important topic. Okay, what are the risk factors, what are the protective factors, and what are the red flag signs. Okay, what are the genetic BRCA1, BRCA2 differences you should know. Okay, which chromosomes, BRCA1, BRCA2, male breast carcinoma associated with which BRCA gene. Okay, all those things are important to know. And if not anything, one breast staging, one carcinoma staging we all must know as an undergraduate is CA breast. CA breast staging is a must know for each and every medical student. So what is TNM, what is T1, T2, T3, T4, we should know. What is very important here to know is T4A. T4A means any size tumor with chest wall involvement. What constitutes chest wall is the ribs, the intercostal muscles and serratus anterior, only three things. If they give anything other than this, like mostly they give pectoralis muscle to confuse you. Pectoralis muscle doesn't constitute chest wall. Please remember, this is the usual question they ask you. Tumor is invading into the pectoralis muscle, what is the stage? That pectoralis muscle invasion doesn't change the staging at all in any way. Okay, so if it's involved into the ribs or intercostal muscle or serratus anterior muscle, then only it is T4A. What is T4B is skin involvement. Again, what are the features of skin involvement? Only three things: Podorage appearance, or satellite nodules, or ulceration. Anything given other than this is not a skin involvement. Okay, only these three features constitutes the skin involvement, that is T4B. T4C is both chest wall as well as skin involvement. T4D is inflammatory carcinoma of the breast. Okay, what is N1, N2, N3, N4, N1, N2, N3 you should know. In N3 you have A, B, C. Okay, and anything contralateral, if the lymph node or present in the opposite axilla, that is metastatic. Okay, if the tumor is there in the other breast, that is metastatic. Okay, and what's the most common site of metastasis? Is a bone, most commonly the lumbar vertebra. You know why? It's Batson's presence of Batson's venous plexus. Some of the posterior intercostal veins, they go into the valvulus Batson venous plexus and they get deposited in the lumbar vertebra, the tumor. So that's most common site of metastasis. Then the lungs, then the liver. Okay, so staging is very must know. What is stage 1, stage 2, stage 3, stage 4, and There are three types. It can be classified into early breast cancer, locally advanced, and advanced breast cancer. Treatment and management of each condition we should know in detail. Okay, and then some complications related to modified radical mastectomy, like any nerve injuries, they can result in what condition. Okay, this is the most commonly asked question again. Chronic lymphedema following mastectomy can lead to Stewart-Treves syndrome. Hope you all know this. Okay, then these are the complications. What are the other adjuvant therapies? They can ask you. What is the indications for chemotherapy? What is the indications for radiotherapy? What is the indication for hormonal therapy? Right? So all those things, indications, and what are the common chemotherapy regimen given? Anybody? What is the chemotherapy regimen for CA breast? Anybody? What is the chemotherapy regimen? It is, anybody? The answers, please. Another 12 days is the exam. You should be well prepared by now. It's CMF or CAF, right? Cyclophosphamide, methotrexate, and the 5-fluorouracil, or CAF, adriamycin, can be given. Okay, so these are not very important for you, nipple discharge, breast cyst and all, okay, for not for the exams at least. Okay, that's it about the breast. That next most important high yielding topic is the thyroid. Just like in breast we had triple assessment, here what we have is the quadruple assessment. One more what is important is, other than the clinical examination, and we have radiological and biopsy, one more what is important in thyroid is the biochemical, that is thyroid function analysis, right? So it makes the quadruple assessment. So any patient comes with the thyroid nodule, you examine and then get a TSH done. If the patient is hypothyroid or euthyroid, then it likely to be malignant. And if the patient is having hyperthyroidism, the chance of malignancy is unlikely, because usually the malignancies are either euthyroid or hypothyroid, never hyperthyroid. Just like BIRATS we had, here we have TIRATS, thyroid imaging reporting and data system. So what is it? You should know. And according to the TIRATS, patient the thyroid nodule can be either benign or very low suspicion of malignancy, low suspicions of malignancy, intermediate and high suspicion of malignancy, it can be classified. Then we get a, depending on the suspicion levels, we get a FNAC done, and FNAC can be further classified into Thy 1, Thy 2, Thy 3, Thy 4 and Thy 5. Thy 5 is conformity of malignancy, and for all these thyroid nodules we have a Bethesda classification to decide about the management. Bethesda type 1 means it's inconclusive. Even after the FNAC we can't tell whether it's malignant or benign. Okay, then we have to get a biopsy done. What is a biopsy in case of thyroid is, what is the minimum biopsy is hemithyroidectomy. You know what is lobectomy, what is hemithyroidectomy, what is total thyroidectomy, what is near total thyroidectomy and all. So minimum biopsy is hemithyroidectomy, that is lobe along with the isthmus. Okay, type 2 is benign, type 3 is atypia. This is the most commonly asked. What is type 4 Bethesda? That is follicular lesion. Follicular, because your FNAC can't differentiate between follicular adenoma and follicular carcinoma. So you need to get a biopsy done for that. Any follicular lesion, immediately you have to get a biopsy done to confirm whether it's a adenoma or carcinoma. Type 5, type 6, biopsy has to be done. Okay. So thyroid scan, there could be a question on thyroid scan also. Okay, about Graves' disease and all. So which is the thyroid scan, in the which metal is used, that is technetium 99 radioisotope is used usually, or else earlier they used to do radioisotope iodine 123 was used. Now we use technetium 99 because of its short half-life, and its very action is very similar to iodine. Okay, these are the different appearances seen in different conditions of thyroid. Like if it is a entire thyroid is hot, that is Graves. Okay, and whether it can be in the thyroid scan, it can be classified into whether it is hot nodule, cold nodule or warm nodule. And questions can be based on the surgery preparations. What are the drugs you give? So what are the anti-thyroid drugs which is contraindicated in pregnancy, and why is Lugol's iodine is given, and how is propranolol given? Okay, all those the drugs before the surgery, and any about the surgery, any questions can be asked. Okay, you should know the incision, what is Cocker's incision, and which is the first vein to be ligated, that is middle thyroid vein, and both the superior thyroid and inferior thyroid arteries are ligated as close as to the gland to prevent injury to the external laryngeal and the recurrent laryngeal nerve. Okay, and what are the other complications? Most common early complication is bleeding, and then intraoperatively there could be injury to the surrounding structures also. Okay, and in patient also in immediate post-operative period, patient can present with respiratory distress, right? Immediate respiratory distress patient can present with, and that could be respiratory distress can be because of three things. What are those? One is bilateral recurrent laryngeal injury. Second thing is laryngeal edema, or third thing could be because of the long-standing thyroid nodules can result in tracheomalacia, weakening of the thyroid cartilage, tracheal rings. Okay, so what is thyrotoxic storm or thyrotoxic crisis? We should know. Okay, how to manage that also. Other complication. What is the most common nerve injured in thyroid surgery? Anybody? What's the most common nerve injured is external laryngeal nerve, but it's not very important. What is the most difficult to manage, or the difficult complication is recurrent laryngeal nerve injury. One in unilateral recurrent laryngeal injury will result in hoarseness or weak voice, whereas if both the recurrent laryngeal nerves are injured, patient may develop stridor. Okay, so again patient has to be intubated in such a condition. Okay, and another post-operatively other complication what you can expect is hypocalcemia due to the injury to parathyroids. Most common type of injury is not the removal of parathyroids, but ischemic injury, because the same inferior thyroid artery supplies both the thyroid and the parathyroids, right? So if you ligated the inferior thyroid trunk, it will the branch to the parathyroids may get blocked, so there is no blood supply to the parathyroids, resulting in ischemic injury, and this calcium metabolism is not happening, so hypocalcemia. Okay, post-operatively, if the patient develops hypocalcemia, you know what are the signs: Jones-Tex sign, Trauger sign, all those things you already know very well. And how do you manage also? See, this has been again question. In a mild hypocalcemia, if it is calcium levels are more than or equal to 7, okay, then we manage with oral calcium supplements. If there is a persistent hypocalcemia, then vitamin D3 can be given. If there is a moderate to severe hypocalcemia, like less than 7 calcium levels, can be always managed with IV calcium. IV calcium, if it's again persists, you can give vitamin D3 or magnesium also. Okay, and different all 4 types of thyroid malignancies you should know in detail. Papillary thyroid, most common type. What is the classical appearance on histology? That's orphan annii, nuclei, and samoma bodies. All those things you should know very well, better than me. Theory aspects. Okay, so please revise them. What's more important is medullary thyroid. In that one, I'll write and give it for you. One, there will be in this exam, upcoming exam, you will definitely get one question on MEN syndrome for sure. For sure, this MEN syndrome, you know, right? What is MEN syndrome? About PTC, okay, FTC, you know. PTC spreads by lymphatics, FTC spreads by blood, hematogenous. What you should know is this medullary thyroid. Please, my dear friends, if not anything, please learn this one chart. What are the components of MEN1, MEN2A and MEN2B? What are the they'll definitely try to confuse you with giving some PPP. Don't get confused, you should know in detail. And which MEN2A and MEN2B can be associated with medullary thyroid cancer. Okay, and you should know that. What are the tumor markers also you should know. Thyroglobulin and calcitonin in case of see, calcitonin is a tumor marker and most sensitive marker of prognosis and recurrence in case of medullary thyroid. even the CEA also. Whereas thyroglobulin is for follicular and papillary. Okay. Anaplastic carcinoma. Okay. Anaplastic carcinoma, you know. Thyroglossal cyst. What is thyroglossal cyst? You know. What is the treatment for thyroglossal cyst is? What is the name of the surgery? Can anybody say? What is the name of the surgery for thyroglossal cyst? If you answer this, you are well prepared for the exam. It's not very difficult. You can tell it. Please answer me. What is the name of the surgery for thyroglossal cyst or thyroglossal fistula? Both the same. Please. Dr. Pragati or whoever, please answer. What is the Praveen is there, Anand. It's your relative and a very close relative. Cis, very good Praveen. I expected that you would answer it. Cis trunk surgery, very good Praveen, excellent. Okay, cis trunk surgery where we take out the entire tract, okay, entire tract of the this thing thyroglossal duct, and also along with that middle part of the hyoid bone also taken out in that. Okay, what is the most common site? The question asked on this is what is the most common site of thyroglossal cyst? This is most common is anywhere in the infrahyoid region. See, this is the hyoid bone below which is infrahyoid. This is the most common site. In that also where exactly is subhyoid, just below the hyoid. Subhyoid is answer should be, if subhyoid in your option, then that is the one, or if not there, infrahyoid is the most common site. Okay, okay. Thyroglossal cyst, you know. Then parathyroids is not very important from your examination. I'll ask some questions. Let's see how much you are prepared. You should answer quickly. Quickly, all of you, please be prepared to answer quickly. These are the all our previously asked question. All of you should answer. Try to answer them. Most common thyroid carcinoma. Quickly, 5 seconds each. Just write the short names. Enough. What's the most common thyroid carcinoma among 4? Is it options are PTC, FTC, anaplastic, medullary? It is somebody please answer. It is PTC, right? Papillary thyroid. What is the least common type of thyroid carcinoma? Least common is different. Yes, very good Praveen, correct. Little quicker. So what is the least common thyroid carcinoma? What's least malignant, which is the most malignant? All those things you should know. See, least common is anaplastic. Least malignant and the most which has got good prognosis is papillary. Most malignant and very dreaded is anaplastic. Most common cancer after radiation exposure is papillary. All these are questions, okay, for you. Cancer developing from previous Hashimoto's disease, okay, that is lymphoma. Thyroid cancer developing in long-standing multinodular goiter, that is they'll give you history like patient is having thyroid nodules since last 20 years. Now suddenly the size of the swelling is increasing in size, but is benign has converted into malignancy, that is into the follicular malignancy. Any benign swelling will give rise to follicular malignancy. Type of thyroid cancer in men syndrome, you know, that is medullary. With associated with the myeloditis, medullary. Some bodies are associated with papillary thyroid cancer. Orphan anenuclei is associated with papillary thyroid. Carcinoma derived from C type of or parafollicular cells is medullary. Carcinoma developing in thyroglossal tract or from the thyroglossal cyst is again papillary. These are all the previously asked questions. Please know them. Okay, that's about thyroid. Next, one topic is which is important for you is Burgers disease. Burgers disease they can ask you, also called smoker's disease. Boyd's classification can be asked. Boyd's classification, patient is having rest pain. Which Boyd's classification is this? Okay, is class so Boyd's classification D type. Okay, and most important is ABPI. ABPI is very important topic and question for you. What is ABPI? Ankle brachial pressure index. Okay, okay. So normal is 0.9 to 1.4. Okay, less than 0.9 suggestive of arterial obstruction, whereas 0.4 or less than 0.4. This will be a question. When do you call it as a critical limb ischemia or rest pain starts at? When the ABPI is less than or equal to 0.4, and when the ABPI is 0.1, patient may develop gangrene. Okay, this one thing please know in this. Okay, and that's it. Burgers disease you know well. That is also called thromboangiitis obliterans, also called smoker's disease. Smoker's disease. Okay. Acute limb ischemia, you have Rutherford classification, and the treatment for any ischemia, acute limb ischemia is initially the first. What is the first drug to be given? That was a question. That is heparin, IV heparin. Okay, IV heparin. Aneurysms we should know. In aneurysm, what they ask question is this thing. What is it? In aortic aneurysm, they will ask you about these two classifications. This is DBMCI and Stanford's classification of aortic dissection. They can ask you. This one thing you should know. DBMCI and Stanford classification. Okay, and thoracic outlet obstruction, they have asked question. Thoracic outlet obstruction or thoracic outlet syndrome it is called. They have asked you about the most common cause is trauma. Other causes are cervical rib ergonomics or because of Pancoast tumor. Okay, and it could be either neural thoracic outlet syndrome, arterial or venous. Okay, see this one particular question what they repeatedly ask you is which is the test used to detect the TOS, that is Adson's test. There are so many other tests. Commonly asked one, commonly used one is Adson's test. Don't get confused with Allen's test and Adson's test. Allen's test is for the patency of the radial and ulnar arteries, whereas Adson's test is for thoracic outlet syndrome. Okay, AV malformation, most common cause is congenital. Okay, AV malformation, that was a question. Most common cause of AV malformation. Most common cause of AV fistula, if they ask, that is iatrogenic or surgical creation for dialysis. You know, that's different. AV fistula is different from AV malformation. Raynaud's phenomenon you have learned in medicine anyway. Raynaud's phenomenon is different from Raynaud's disease and Raynaud's syndrome. Phenomenon is a sign. Okay, it's because on exposure to cold or stress, the because of the vasospasm of digital arteries resulting in the cyanosis of the fingers. That's called Raynaud's phenomenon. If this happens in a young ladies as an idiopathic cause, then it's called Raynaud's disease. If there is a patient having connective tissue disorders, they develop Raynaud's phenomenon. It's called Raynaud's syndrome. Hope it's clear. Is a isolated, the vasospasm is called Raynaud's phenomenon. If this happen in a young lady with a idiopathic cause, it's called Raynaud's disease. If this is associated with some connective tissue disorder, then it's called Raynaud's syndrome. Okay, then the next most important topic is venous disorders, in which they'll ask you about the varicose veins classification. What is the classification we use for varicose veins? Somebody please answer. Nowadays, recently we have one classification system for varicose veins, right? What is that? C. There will be a question based on that. This one, CEAP classification. There will be one question on this. What is C2 they can ask you. What is C3 they can ask you. Okay. What is C4, like that you should know. What is okay, mainly about C only. C classification they ask, not the etiological analysis. This is theory question. Whereas for MCQ they'll ask what is C4. What is C4A they can ask you, like that. Okay. What is C6? It's active venous ulcer, like that. This one thing please chart. It's available everywhere. It's there in your notes also. Please look into that again. Okay, treatment and all not very important for you. DVT is important. DV is virtuous triad of DVT is important. Okay, and most common vein they have asked involving the DVT, that is calf veins. And what's the most common complication of DVT is pulmonary embolism. That you should know what are the different signs of DVT. Mosses sign, Homan sign, Linton sign. These three are important for you, and this you should know. Modified Wells criteria for predicting DVT and also predicting pulmonary embolism. Modified Wells criteria. Okay, modified Wells criteria for predicting pulmonary embolism. Treatment, you know, it is low molecular weight heparin for DVT. That's it for about venous disorders. Next, questions can be on hernia, right? Hernia is an important topic for UGs. So, what is hernia? You know, hernia. They can ask you about the procedures. Some hernia procedures they can ask you, and about the see mainly this EHS classification. Nowadays, last time they had asked you about one EHS classification question. What is PL1? What is like that? What is P is primary, L is lateral. Lateral is indirect hernia, whereas M medial is direct hernia. Okay. Name, yeah. This one slide will fetch you one question for sure. This one slide for you. Named hernias. One question can be there. What is Litter's hernia? What is Amiant's hernia? What is Madel's hernia? What is Pantaloon's hernia? What is Gibson's hernia? All those things. Any one can be a question for you. From this hernia, this is the favorite question of examiners. Hernia surgeries, you know, herniotomy, herniorrhaphy, and hernioplasty. Okay. That's about the hernia. Nothing much in hernia. Only named hernias you should know. Named hernias, if you know, that's enough at your level. Okay. Next important topic would be systemic surgery. Systemic surgery starts with esophagus. Esophagus, you should know two topics in detail. That is, one is GERD, another one is achalasia cardia. Okay, what is a GERD? What is the investigation of choice for GERD? What is the treatment for GERD? Okay, what is achalasia cardia? What is the investigation for achalasia cardia? What is the treatment for achalasia cardia? All these things you should know. These two topics, if you know very well, enough. Okay, from this and carcinoma and all, not so important for your level. GERD, what is you should know. GERD, what is the investigation? Investigation of choice for GERD is endoscopy, because you can see that relaxed sphincter there. Okay, and also esophagitis will be there. What is the gold standard is 24-hour pH monitoring, because of the reflux of the acid from the stomach to the esophagus. That will tell you the real severity of the GERD. So that's the gold standard. Of that of achalasia cardia is manometry. High resolution manometry is the investigation of choice. Okay, the surgery for GERD is fundoplications. Fundoplication. Achalasia cardia is myotomy. Heller's myotomy. Okay, what are the complications of the GERD is Barrett's esophagus. See, again a question asked, what happens in Barrett's is squamous metaplasia. Squamous cells metaplasia into columnar cells. They get dysplastic into the malignancy. Okay. Hiatus hernia. Types are there. Hiatus hernia, type 1, type 2, type 3, type 4. Okay. Again a question. Perforation is not a question for you. Corrosive injury is fine. Not Zenker's diverticulum. That X-ray can be kept. Okay. That was the image-based question for you of Zenker's diverticulum. Last 2-3 years back it was asked. One barium swallow image they will show you, and there is outpouching you can see in the neck. That is Zenker's diverticulum. Posterolateral outpouching in the esophagus is called Zenker's diverticulum. Okay. Next question, what they asked last time is from intestine. About Hirschsprung's disease they had asked you, and about the intussusception there was one question. There was a question on intestinal obstruction also. So intestine topic not very important for you, but you can just glance through it once you know. Okay, through your notes. What are the features of intestinal obstruction? Okay, And what are the different causes of intestinal obstruction? You should know. What is Ogilvie syndrome? What is Ogilvie syndrome? Pseudo obstruction of colon is called Ogilvie syndrome. That was question. And yeah, this was the question. Intussusception. Intussusception, you know, the telescoping of the bowel. One part of the bowel inside the other is called intussusception. Okay, it's most common in children. It can also happen in elderly. Okay, see that signs. The question can be depending on that where you get target sign, where you get donut sign, where you get bull's eye sign. All these things can be a question. The answer is intussusception. Most common type is ileocolic type. Meconium ileus and Meckel's diverticulum, rule of two for Meckel's diverticulum. And okay, TB intestine is not very important. Mesenteric cyst is not important. Yes, Hirschsprung's disease was a question for you. Hirschsprung's disease, also called congenital megacolon. Okay, just like it's a counterpart of achalasia cardia. There the esophagus dilates. Here the colon dilate. It's called congenital megacolon, also called Hirschsprung's disease. Okay, so second thing is volulus. The typical question is, what is the appearance, X-ray appearance of volulus? See, this is a coffee bean appearance seen in sigmoid volulus. Okay. This is the sigmoid volulus. Whereas if this is a see, if this side, this is cecal volulus. Okay, this is cecal volulus. If this is pointing the beans, that what are the inner part is that it is, if it's pointing towards the sigmoid colon, that is sigmoid volulus. If it's towards the cecum, it's called cecal volulus. Okay. Then the rectal prolapse and is not question. CA colon also not commonly asked for you. What can be asked is next hemorrhoids, fistula. You should know hemorrhoids and fistula. Appendix can be a question. Appendix can be a question for you. What's Alvarado score was asked. What is Alvarado score? Which of the components have got given 2 scores in Alvarado scores? You should know. Okay, that's about appendix. And in anal canal you get all those things, fistula in ano or hemorrhoids. Okay, in fistula what you should know is Goodsall's rule. Goodsall's rule was a question. And the types of fistulas are there. Types of fistulas can be Park's classification. You have submucosal, intersphincteric, transsphincteric, suprasphincteric and extrasphincteric fistulas are there. And what the treatment is, either fistulectomy or fistulotomy can be done. Hemorrhoids, either primary or secondary hemorrhoids. Okay, you should know. And the grading of hemorrhoids, first grade, second grade, third and fourth grade. Treatment is in the initial stage you can give medical treatment, and also you can do some sclerotherapy or laser or banding of the hemorrhoids. But in the later stages, stage 3 and stage 4, you have to do hemorrhoidectomy. Okay. Next important topics would be our liver, pancreas, gallbladder and stomach. Okay, liver, in that liver cancer can be a question. Okay, and else liver abscess. There are 2 types of liver abscess: amoebic liver abscess and pyogenic liver abscess. How do you differentiate? Mainly that will be a question. Okay, pyogenic and our amoebic liver abscess. Then hydatid cyst. Hydatid cyst is caused by, and what is that classical appearance you get in hydatid cyst can be asked. Okay. Hepatic neoplasms, I told you HCC, and then the most common type of they have asked. What is the most common type of hepatic neoplasm they have asked? That is secondaries. Okay, secondaries are more common than the primary hepatic carcinoma. Okay, so what are the risk factors for the liver cancer, and what is the treatment for liver cancer? You should know. Next thing would be gallbladder. Gallbladder is not very important for you, and even the pancreas acute pancreatitis, some questions can be, or can be there, or related to other malignancies like gastrinoma, vipoma, the insulinoma. This can be a question from pancreas. Okay, pancreas is not very important, but please read about this one, PNET. These are the very small topics but very important one. PNET, endocrine neoplasm of the pancreas. Like you have insulinoma, gastrinoma, some which cells and what are the classical features or triads are there in insulinoma, gastrinoma, glucagonoma, vipoma, and somatostatinoma. You have typical features are there, so you can know them. Okay, it's good to know. Last year's question was this: what is the triad of gastrinoma triangle? Triangle of gastrinoma, that's called Pazzaro's triangle. So boundaries was asked. Pazzaro's triangle boundaries. Okay. Okay, and then the stomach cancer, peptic ulcer and stomach cancer are the important questions. At H. pylori, the stomach cancer, what is it that complications of the surgeries they have asked in the stomach. Okay, complication of the what is Billroth 1, what is Billroth 2, what is ruined by gastrojejunostomy. Their post gastrectomy, so many complications can happen. This was the question. See, last time question was duodenal stump blowout is common in, that is between day 4 to day 7. If they ask you in that particular day wise, 4, 5, 6, 7, fourth day is the most common. Okay. Then there are dumping syndrome, afferent loop syndrome, efferent loop syndrome. Okay. Yes, very good, Dr. Muhammad. Water lily sign, correct. And Muhammad Anash has correctly answered the triangle, that is Pazzaro's triangle. Excellent, excellent. Prepared well. Okay. Surgery is a easy subject for you, and you should be very much confident with this subject. Okay. So so that you can answer well. Dumping syndrome, and yeah, ulcer disease is important. Ulcer disease, that is peptic ulcer disease. And what is Cushing's and what is Curling's disease? Curling's ulcer, you know, right? What is Curling's ulcer? What is Cushing's ulcer? Can anybody say what is Curling's ulcer? What is Curling's ulcer? Can you say? Where do you get Cushing's ulcer? Where do you get Curling's ulcer? Please tell me. Yes, very good, Anash. Very good. Burns, you get Curling ulcer. Excellent. Cushing's ulcer? Very good. Cushing's, please fast. Please be fast. You have only 5 seconds time to answer this. Yes, very good, Khan Saab. Very good. You are prepared well, really well. Okay. And all these are theory questions for you, not important for your MCQ point of view. Okay. Gist, carcinoma, stomach, and all, not very important. Don't worry. What's more important is our urology topics. Last time there were some 6-7 questions on urology topics. Okay. About torsion was there, hypospadias. Okay, I'll just discuss one by one. In urology, first common question was renal stones. Renal stones, in that this particular question was asked. See, where do you get which type of crystals? If they give you as envelope type of, see, they'll give you an image like this. Envelope type of crystals are seen in which condition? Seen in calcium oxalate dihydrate stones. Dumbbell shaped crystals are seen in calcium oxalate monohydrate stones. Whereas amorphous sharps and blades type of crystals seen in uric acid stones. Most commonly asked is this is coffin lid shaped crystals seen in struvoid stones. Needle shaped in bruchide stones. Okay. So these were the questions on renal stones. You should know. See, images like this can be given for you. Okay, yeah, very good, Ansh, very good, excellent. Okay, And next important topic for you, one is renal stones. Read about that, renal stones, different types of crystals and all. Second thing is one about staghorn calculus you should know. What is staghorn calculus you should know. Okay, it's a triple phosphate stone. And the second thing is BPH is important for you, not BPH. RCC is not important. Prostate, in that BPH is very very important. Please know about BPH. Yeah, and in urethra they had asked about this hypospadias. What is hypospadias? It's the most common congenital anomaly of lower urinary tract, and it's the most common if they ask you what is the most common obstructive congenital anomaly of lower urinary tract, it is posterior urethral valve. Okay, whereas most common congenital anomaly if they ask you, that is hypospadias. Okay, hypospadias, epispadias, what is it, you know. Okay, already. And what is phimosis? This was the question. Phimosis, inability to retract the foreskin is called phimosis, and inability to put back the retracted skin is called paraphimosis. Okay, CA pen is not very important. Yeah, this is important, very very important, and its complications also. BPH and its complications is very important. And BPH, so you know what is BPH, and what are the complications can be associated. And the treatment for BPH is hypospadias, circumcision. Yes, very good, correct. That is again a question. If you really good, I'll ask a very difficult question. What is the typical appearance you get in hypospadias? The skin appearance. If you answer that, you will be definitely within top 50. Muhammad Khan Saab. Khan Saab, boliye. What is the sign you get in hypospadias, especially in glandular variety? How the skin looks like, the foreskin. Okay, the test, okay, that's called hood sign, cobra, hood sign, okay, hood sign. So in the testes, they asked you about this undescended testis. Last time's question was undescended testis. Okay, undescended testis was a question. And what are the causes for undescended testis, also called cryptorchidism. And what's the treatment for undescended testis is orchiopexy, bringing down the testis and fixing it. It's called orchiopexy. And another question was this testicular torsion. Testicular torsion was asked, and a patient means they'll give a history, like the young boy presented with a sudden after fall or while cycling he fell and sustained injury to the scrotum. Okay, so then comes up with the very painful scrotum they'll give you. And how do you differentiate between the torsion and the epididymoarcheitis is called, this is called prehensine. This was asked. Okay, if you elevate the testis, if the pain increases, it is called testicular torsion. If the pain decreases on elevation of the scrotum or the testis, then it is epididymoarcheitis. Okay, that's all about the urology topics. Okay, and some image based questions can be asked from you. Instruments, some 2-3 one commonly asked is this Foley's catheter was asked last time. I'm giving just orientation here. I'm not going to the details of each and everything. It will become a very lengthy class, and I know you're not very interested to go into the details because you just want what is very important for the exams so that you can revise them. This was the question last time. What is this? Foley's catheter, and other similar. This is Ryle's tube, right? This is Ryle's tube. Any instrument can be asked as image based question for you. Image based question. One more thing what you can know for a better scoring is sutures. Different types of sutures you can know. See, this can be asked like this. One instrument can be kept like this. And what is this? Can somebody say what is this now? Answer this. Let's see your preparedness. I'm not checking your knowledge, but your preparedness. This is not Doyen's. It's a L shape. See, this is the shape of L, right? Shape of L. So it should be Langenbeck's. Langenbeck's. Okay, Langenbeck's. If it is shape of Z, like this, another instrument is there. Okay, that is Z shape. So Zernis. Zernis. Okay. Like those are the confusing. See, this is Z shape. So Zernis. Okay, I'm making it simple. It's not named like that, but I'm just trying to make it very simple for you. If L shaped you see, that is Langenbeck's. Morris and all very big ones. Big, what is that? At least mouth will be there. Okay. See, Morris are not included here. And the tubes can be asked like any tube. Mostly these Foley's and Riles tube are asked because, and this chest tube drain, you know. Okay. That's about all the instruments. Yeah, this one chart I told you to know this one. Okay, which size of cannula, IV cannula? This was a question last time also. See, what is this? Can anybody say now? I'm giving some spotters for you so that you can answer. So this will be like a mock exam for you. Can somebody answer what is this? I don't know banana and all. You tell me what is the condition, Ansh. Whether it is EDH, SDH, SAH. Yes, very good. See, your preparedness is very good. SDH, it's a concavo-convex, right? This is a concavo-convex shape. So, it is a acute SDH. Okay, acute SDH. EDH would have been like this, biconvex. See, this is EDH, biconvex like this. Clear? So, any doubts? If no doubts, we'll end it here, end the class. Okay. What is this? Can anybody say? Can somebody answer this? This X-ray can be given. What is this? Don't think very hi-fi, very simple. Very good, excellent, excellent, Bhargavi and Ansh, excellent. It is, yeah, it's a tension pneumothorax only, not just pneumothorax. Why? Because there is a mediastinal shift is there. See, trachea. Can you see the trachea here? Trachea shifted to the, and the heart also almost shifting to the right side. Very good. So this is a tension pneumothorax. Can you tell what is this? What is this? You are very good, okay? These students are very, very good. Really happy. What is this? Very good, Mohammed Amjad. It's a hydropneumothorax. Very good. Okay. So like that. Can somebody say what is this? What is this maneuver called? Maneuver to control the bleeding in any liver injury. There's a liver laceration here. Liver laceration and it's bleeding profusely. What maneuver we use to control the bleeding from the liver? See, this hepatic artery is the main hepatic artery and the portal veins, right? So we are occluding that to control the bleeding. Very good, Ansh. Anash, no? Anash is excellent. Definitely within top 100 this time. Anash, excellent. Okay. What is this? Can anybody say it was? What is this? It's a spotter for you. What is this? It's taken out of from a psychiatric patient, girl. Very good, Anash. Trichobazor, very good. Trichobazor, excellent. Okay, what is this? What is this X-ray? Very good, correct. Trichotillomania, very good. Also called Lopenzil syndrome. What is this now? No. What is the diagnosis here? I want to know. What is suggestive of this X-ray? Dilated livers, dilated intestine. Where you get? It's intestinal obstruction. See, this jejunum, valvulae conjunctus. You can see here prominently. Small bowel is small bowel obstruction. Okay, so that's it. Any other doubts? Say this one blade important. Okay, so many times they have asked this question. I wanted to highlight on this one thing. Please know types of blades, different types of surgical blades. Okay, so what they can ask you is see, this is sharp like blade, sharp like this. This is called 11 number blade, used for incision and drainage of abscess or any precise incision you want, like arteriotomy, tracheostomy and all. You use this blade, 11 number blade. Okay, and this 15 number blade used for small excisions, also called D type of blade. D, small excisions. And for major surgeries, for big surgeries, you use this 22 or 23 ones. Okay, this one thing, please, mainly they ask about this 11 number blade. You should know IND. Okay, so last time one more question asked was that ureterocele was what is the appearance you get, that you already answered, adder head appearance or cobra head appearance. Okay, that's all. Any other doubts? This can somebody tell what sign is this and where do you get this? What sign is this and where do you get this? Common Firo. Yes, very good, Anash. Very good. I really happy. Excellent, Praveen. Excellent. Mickey Mouse sign. Very good. Seen in which condition? Very good. What is this instrument? Seen in varicose veins. Okay, varicose veins. What is this instrument? Can't see here. What is this instrument? Yes, very good. Humbee's skin grafting blade. Okay, skin grafting knife. Sorry, blade is Eastman's blade we use. Okay, pneumatic stockings. Okay, gas gangrene, so many. Okay, these are the some spotters. Yeah, what is this? What is this? Can somebody tell? What's the diagnosis here? What is the answer? Very good. It's ranula. Excellent. Okay. So that's it. Okay. If you have any doubts, you can ask me for another 5 minutes or so. Then we'll wind up the session. Okay. It's already been a long time for you. I know I'm disturbed in the middle. Sorry about that. I wasted your time. I'm really sorry about that. Can you please instrument is very important topic. Instruments, okay, image based. Any doubts you have, you can ask me now. I'll try to solve your doubts. Thing is that you have read well, okay, you have prepared well. Only thing is you need to be very confident. You need to be very confident about your examinations. Hard work plus the success formula is hard work, which you already done, plus self confidence equal to sure success. If any one of this missing, success can't be guaranteed. Okay, you do hard work, I agree, but if you're not confident in yourself, it's not achievable. Okay, but you are very confident, but you're not working hard, even then it's not possible. Okay, so just revise. Don't go to read anything new now. Another 10 days or so, keep revising your notes. Cancer staging, Praveen, no, it's not very important for you, but once or twice oral cavity staging was asked, but not very important. What is important is only see a breast. Please learn that and go. Enough for your level. Enough. Okay. Shanwas Khan telling Happy New Year in advance. Thank you. Wish you the same. Hope the class was useful, right? Class was useful, except for that delay or in the interruption. Sorry, that was unavoidable. Sorry about that. Any other doubts? Please give a thumbs up if it was useful. Thumbs down if it was just a waste of your time. Grafting, Ayengi sir. Yeah, grafting. Yeah, I told you that instrument can be asked, and yeah, two types of grafts can be asked. What is that? What is Thier's graft and what is Wolf's graft? Full split thickness graft and full thickness graft can be asked. From where do you take the full thickness graft? Where there is a redundant skin is there, like in the upper eyelid, in the elbow, where there is excess or redundant skin is there. In the supraclavicular fossa, you can get full thickness graft. For small defects, you can use. If not, you use split thickness graft, also called Thier's graft, mostly from the anterior part of the thigh. That can be asked. Good doubt. Anything else? If no doubts, shall we end the session? I think you're all in the mood of New Year celebration now, I'm sure. So I don't want to disturb your celebrations. So any doubt, anytime, let me know. Okay, I'm always there to help you. You can mail me at surgeon kishan@gmail.com. Okay, you can mail me. Okay, surgeonkishan@gmail.com. Any queries you can ask in this. Okay, yeah, Shanwas is asking me to read his shayari, what is written. जब आंखों में अरमान लिया, मंजिल को अपना मन लिया, फिर मुश्किल क्या और आसान क्या, थान लिया तो थान लिया. वाह 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 वाह. यस करेक्ट, मोहम्मद शहनवाज इज करेक्ट. हाँ सर, हमारा न्यू ईयर 12th को होगा, नॉट फर्स्ट. ओके, गुड. दैट्स द कॉन्फिडेंस. द डे you write your exam. Sir, will this session and PYQs enough? No, not at all. Not at all. Okay. Yes, PYQs is a must. I just highlighted, given an orientation to you, which are very, very important, must know things. but you have to revise through your notes. Okay, revise through your notes. And PYQs, definitely all the PYQs you should know, you must know, because if they repeat it, everyone will write the answers. If you miss it, you will be the loser. So PYQs you must know, and you should get them right. If you miss them, your ranks will fall significantly. And notes, please revise your notes. That's enough. Okay, at this stage only revision of your notes is enough. Don't go to read anything new, and give as many mock tests as possible, please, because solving an MCQ is an art. Doesn't come on the exam day suddenly. So practice MCQs, as many MCQs as possible. Every day try to give one grand test for 3 hours, so your mind will be well adapted or well equipped for that time. If you think if your exam time is 9 to 12, every day 9 to 12 write one grand test, so that your mind will be alert, the presence of mind will be good. And how much ever you read, the questions will be different. You don't get direct questions. It's all application based from whatever you read. So if you try solving as many MCQs as possible, that will help you rather than keep on reading. Okay, another 10 days focus mainly on solving MCQs. That will definitely help you. I'm sure you will do well. I'm very sure you will do well. Be confident. Don't think anything negatively. Okay, don't be pessimistic. That will affect the hormones. Such hormones will be released, and the results will be that. So you become what you believe. Okay, remember this. If you think positively, good hormones are released, and the actions will be accordingly, and you will succeed. So we become what we believe. What we believe. You believe that yes, I am going to do my PG in AIMS. You believe it today, and automatically you can achieve it by the hormones produced in your body. Okay, first thing is you have to believe. Conceive an idea, believe in it firmly, and then automatically you will achieve it. Okay, without belief is the strongest system in the world. Belief system, it's not skeletal system, it's not the cardiovascular system, no, belief system. So believe in yourself. Yes, the 4th year MBBS was the toughest exam. We thought we will fail, even then we passed. First year MBBS was still toughest, we passed. So this is yet another exam. Okay, you know everything. Just that you need to have a focus, presence of mind during that exam time. You will do well. Don't worry about your GT marks and all. Okay, because intentionally they give very tough questions in GTs. Yes, but our mindset matters. Correct. Okay, don't worry about GTs. This is final exam is going to be medium level, not the tough level. So you will do well there. Okay. Thank you so much. Thank you for your valuable time and patient active participation. Any doubts, mail to me. I'll get them solved. Okay. Thank you so much once again.